My name is Prathima Shambag. I am the Child Abuse and Neglect Fellow here at Cincinnati Children's. We are called the Mayerson Center for Safe and Healthy Children, so we are a child advocacy center. And today I've been asked to review with you all some of what you'll be expected to know for your pediatric board examination. So I posted here the American Board of Pediatrics General Pediatrics Content Outline. I pulled this from the one that they published in September of 2017. And I wanted you guys to note that child abuse and neglect is weighted at 4%. That is the same as other specialties like hematology, ortho, endocrine, critical care. So it's really important that you spend some time looking through these questions and material. And this outline is not as detailed as the outline from years prior, so I encourage you all to spend some time reviewing what I don't cover today, because it's material that's worthwhile for your education and for your practice. But things that you might be expected to know, epidemiology and risk factors for all the categories of abuse that are listed on this slide, the physician's duty to report, and the management of children that are presenting with various categories of abuse. But specifically today, I've been asked to review injuries frequently suggestive of non-accidental trauma, as well as signs of prior sexual abuse in children. So we're going to start with bruises, and there are some key points that you should all know when you're given the story or a picture of a child that presents with a bruise. So of all the physical abusive injuries, bruises are the most common. Secondly, we can't date a bruise. So if the question is asking you the timeline or the age of abuse, they're likely trying to trick you. And when you're presented with a bruise in a child, consider the child's age and developmental capabilities. We know that bruises are rare in children younger than 9 months, and especially rare in children that are younger than 6 months. Bruises are also rare in children who are unable to cruise. These injuries should raise suspicion and prompt consideration of abuse. And this is an important point. There is no injury that is quote-unquote diagnostic of child physical abuse, but there are injuries that on the board exam should point you in the direction of abuse as a diagnosis. The most common sites of abusive bruises are on the head and the face, and that's a question that they may ask you. And keep in mind that pattern bruises are also highly concerning for physical abuse. Objects either leave the outline of the object or the imprint of the object on the patient's body, and I have examples of this in a minute. So this mnemonic, 10-4, it's a quick and easy way for you guys to remember bruises that are concerning for abuse. I will tell you that since its creation, the mnemonic has grown, but for the purposes of boards, I would add the letter P. So we'll walk through it. Torso for T, ear for E, N for neck, and 4. So any bruising in children less than or equal to 4 years, particularly these areas, and then any infant under the age of 4 months. And then P again is for pattern injuries. So this disclaimer, the photographs on the following slides are property of Cincinnati Children's and should not be distributed. I also want to tell you that these pictures are graphic and they can be very upsetting, so take some time to take care of yourselves when you're looking through these slides. Okay, so if we walk through that mnemonic, torso for T, we have E for ear, and you can see that you have to keep in mind that you're looking at every aspect of the ear. And then N for neck. P, so 10-4P for patterned. You can note the loop marks that are present on the right bottom and thigh. And this child eventually disclosed that he had been struck repeatedly with a looped thin cord. And then in this child, you see this loop mark on the left thigh, and this child disclosed being struck with a belt. So the board exam will likely present you with a variety of other findings, whether that's in the history, the lab workup, or the physical exam. So as in all questions, read the vignette carefully to avoid any tricks. I'm going to briefly review the differentiating factors between a few of the disorders commonly confused with physical abuse. This is by no means an exhaustive list, but please review these diagnoses in greater detail because they are also likely to be tested. And as you study for the board exam, try to make connections between the different areas being tested. So for example, while you are studying the long list of hematologic conditions you need to know, pay special attention to what their similarities and differences are with other diagnoses. So number 1, Mongolian spots. They're also known as congenital dermal melanocytosis. They'll be present from birth and are usually blue-gray patches with irregular borders. And they're usually present on the sacrogluteal regions, and they can be present on the shoulders as well. HSP, remember the buzzwords of palpable purpura without thrombocytopenia, as well as the remaining clinical features. A child with neuroblastoma may have periorbital ecchymosis that is caused by orbital metastases. And bleeding disorders. So there is a very long list: hemophilia, von Willebrand, fibrinogen disorders, vitamin K deficiency, factor deficiencies, thrombocytopenia, leukemia, aplastic anemia, platelet function abnormalities. Most of these have a history of mucosal bleeding, and keep in mind that they may present you with a family history in the vignette. And then lastly, the vascular type of EDS, also known as EDS type 4, can present with easy bruising, but it will also have other clues such as visible veins or translucent skin, the rupture of arteries, uterus, or intestines, and distinctive facial features, so a thin nose, a thin upper lip, small earlobes, and they may also have a family history. So moving on to fractures. There are again some key points you should know. Fractures are the second most common child physical abuse injury following bruises, and they're more commonly sustained in children under the age of 18 months. Again, there's no fracture that is quote-unquote diagnostic of physical abuse. There are, however, fractures that are highly suspicious, and we are going to go over those. But first, the boards will likely present you with a vignette that will point you in the direction of being suspicious for abuse. Certainly, fractures, particularly in non-ambulatory children with no history, are highly concerning. Inconsistent stories, or stories that don't quite fit the fracture pattern or the mechanism doesn't fit the fracture, are also suspicious. There may be a delay in seeking care, which is concerning, or children who present with multiple fractures or multiple fractures that are in different stages of healing. Essentially, you want to consider the following: the child's age and development, the history and mechanism, the fracture location and age, as well as the presence or absence of other injuries. The AAP recommends that any child under the age of 2 should have a skeletal survey performed when they are being evaluated for physical abuse. And it's important to note that this is not the same thing as a babygram. So listed here are the fractures that we consider highly specific for physical abuse. The exam may present you with a radiograph of these injuries and expect you to know its clinical significance. I'm going to review CMLs and rib fractures in a moment, but I suggest you remember the remaining free scapular, sternal, and spinous process fractures as those that are in the midline, and knowing that that location is pretty difficult to injure accidentally. The classic metaphyseal lesion is commonly referred to as a CML, but it's also known as a corner fracture or bucket handle fracture, depending on the projection of the radiograph. In this projection, you can see what looks like a bucket handle appearance of the fracture of the distal left tibia. A bucket handle fracture is not the same as a buccal fracture, and this is a common trap on the exam. The CML is highly specific when it occurs in the first year of life, and it's a fracture through the primary spongiosa of the metaphysis. They occur when an extremity is twisted or pulled, so a history of a 9-month-old falling and landing on her side would not be consistent with this fracture pattern and would therefore be concerning for physical abuse. Rib fractures are also highly specific for abuse, especially when they are posterior medial. This patient was found to have multiple bilateral rib fractures. Easily visible on this view are posterior right 5, 6, and 7, and posterior left 6 and 7. They occur from anterior posterior compression of the chest, so infants who are held around the chest and squeezed. There are other diagnoses or other causes of rib fractures because, again, there's no injury or fracture that is singly diagnostic of physical abuse. However, you will be likely provided with a history of these other traumatic mechanisms. I've listed here the fractures that are considered moderately specific for physical abuse. I'm sure you can imagine that given a plausible history, some of these are more easily accidental. However, keep them in mind when you are taking the exam. The fractures are considered common in physical abuse but have low specificity are clavicular fractures, long bone shaft fractures, and linear skull fractures. So there are a number of other possible diagnoses to consider. Certainly accidents do happen, but consider the history provided in the vignette as well as other possible injuries that are present on the child. Again, I'm going to briefly go over these diagnoses, but this is not an exhaustive list. So Menkes disease, also known as Menkes kinky hair syndrome, is a rare congenital defect. You'll likely be presented with other findings that are suggestive of Menkes, such as sparse kinky hair, anterior rib flaring, and failure to thrive. Copper deficiency is also rare and can present in children with severe nutritional disorders like short gut syndrome. Other findings will include hypotonia, hypopigmentation, and sideroblastic anemia. Scurvy, vitamin C deficiency can occur in children who drink cow's milk exclusively or have absolutely no vitamin C in their diet. And there can be metaphysical changes, but there will be also other findings such as soft tissue hemorrhages and osteopenia that will point you in the direction of scurvy. Demineralization, so children with severe disabilities limiting or preventing ambulation can be at risk for fractures even with normal handling due to the demineralization. However, keep in mind that children who live with disabilities are at a higher risk of physical abuse. Osteopenia of prematurity, you will have clues to the patient's history of prematurity, a history of PPD or a BPD, or a prolonged use of TPN, diuretics, or steroids. It's particularly a complication in children who are born before 28 weeks or who weigh less than 1,500 grams at birth. However, keep in mind that premature infants are also at an increased risk for abuse. OI, this diagnosis is often suggested by short stature, blue sclera, poor dentition, a family history of fractures, radiographic evidence of osteopenia, as well as a number of other clinical features. Fractures are usually transverse and are located on the long bone shafts. The board exam is likely not going to try to trick you here, but rather test your ability to recognize or rule out OI when child abuse is a possibility. Osteomyelitis. In infants, osteomyelitis can present as multiple metaphysical irregularities that can have the appearance of a CML. However, remember that there are going to be other signs of infection that you will be presented with: fever, elevated ESR, CRP, white blood cell count. And then lastly, systemic disease. Consider things like chronic renal disease and chronic liver disease as well. So moving on to burns, which is pretty straightforward. Inflicted burns can be differentiated from accidental burns by their pattern. You will see sharply demarcated lines and a symmetric distribution, and they will likely be on the lower half of the body. You may be given a history of a child who's being potty trained, as toileting accidents can often be a trigger. Object contact burns can be inflicted with items such as irons or cigarettes. Inflicted contact burns are usually deeper than accidental burns. And then we ask you to consider the history, the number of injuries, and the characteristic of the burn over a curved part of the body. As always, remember there are other diagnoses to consider. For example, senna containing laxatives can cause a chemical burn to the buttocks. Moving on to oral injury, there are a number of oral injuries that can be found in patients who are victims of physical abuse. Classically, we think of them of the frenulum injury. However, there are several other types of oral injuries: the tongue, the lip, the mucosa, the palate, the teeth. And the teeth, there have been case reports of fractures, displacements, as well as avulsions. As always, consider the age and the developmental stage of the child, as well as the history of the injury you're provided with. In this photograph, you can see there's a healing injury to the child's superior labial frenulum. And remember, there's also the inferior labial frenulum and the lingual frenulum that need to be checked. The second leading cause of child physical abuse death is abdominal trauma, and it is most commonly affecting infants and toddlers. On physical exam, you'll likely not see any overlying bruising on the abdomen. And while solid organ injury, usually the liver, is more common for both accidental and non-accidental abdominal injury, children who have been abused are more likely to also have a hollow viscous injury. And because abdominal injury may be masked by other injuries or findings, when abuse is suspected, LFTs and pancreatic enzymes are obtained, usually followed by an evaluation with the CT. So moving on, head trauma is the leading cause of child physical abuse death and commonly occurs in infants. The mechanisms of abusive head trauma, which I want you to note that it is no longer called shaken baby syndrome, includes shaking and blunt impact. Crying is often the trigger, and convicted perpetrators have confessed to this in the past. The presentation of a child who has sustained abusive head trauma may range from being asymptomatic to a range of neurologic signs and symptoms, including lethargy, emesis, irritability, apnea, and seizures. A head CT is preferred to evaluate the acute injury, and an MRI can later evaluate the extent of the injury. Its definition is an injury to the skull or its intracranial context due to inflicted trauma. But the ones that we classically see are subdural hemorrhage, although you can see other head injuries such as subarachnoid hemorrhage or skull fracture. Retinal hemorrhages, which are detected by indirect ophthalmoscope. particularly those that are extending to the ora serrata or involving multiple layers of the retina. Retinal hemorrhages are not necessary for the diagnosis, and they can also be caused by severe accidental trauma, coagulopathy, or leukemia, but you'd likely be given that history in your vignette. And then certainly you can have other cutaneous, skeletal, and visceral injuries. Again, try to consider the history you're presented with. A 3-month-old who presents with bilateral subdural hemorrhages and posterior rib fractures with a history of a short fall after rolling off of the bed is highly concerning for physical abuse. Okay, now that we have briefly covered physical abuse, let's transition to sexual abuse. I'd like to start with a quick review of anatomy. This is a photograph of a prepubertal female in the frog leg position. The examiner has applied a small amount of labial traction in order for us to see the anatomy. We're going to start at the top arrow and move our way downwards. And as we go through, you'll see boxes popping up with the answer of what each anatomical part is. So if you know it, try to think it as we walk through. So that exterior skin is the labia majora. As the child ages and goes through puberty, that's where her hair will grow. That's where the urethra is. That inner skin fold is the labia minora, and you can see it joining together at the top at the clitoral hood. This is the hymenal orifice, and this is the hymenal ring. This space is the fossa navicularis, in between the hymen and the posterior fourchette. We always refer to locations of the hymen as if a clock face is superimposed, with 12 o'clock always near the urethra and 6 o'clock always near the rectum. The area referred to as the posterior hymen is usually between 3 and 9 o'clock, and the hymen can have different variations. The one photographed here is annular, meaning it is a complete ring. A crescentic hymen looks like a crescent with an absence of tissue, usually between 10 and 2 o'clock, both completely normal. It's also important to note that as the female goes through puberty, the hymen becomes less pink, more white, thicker with redundancies and folds, and loses its sensitivity to touch. Okay, so the American Board of Pediatrics wants you all to recognize that for most children, in fact, more than 95% examined for sexual abuse will have a completely normal physical exam. The small percentage of children who don't have a normal exam will have one of these concerning findings: genitalia abrasions or bruises, hymen injury, posterior hymenteric extending to the base of the hymen, posterior fourchette or fossa navicularis injury, and anal lacerations or bruises. And few children, about 5% of children who are sexually abused, acquire a sexually transmitted infection. So let's walk through them all and their implications. The first 4, gonorrhea, syphilis, HIV, and chlamydia, are considered diagnostic of sexual abuse. There are exceptions, however. As you know, all 4 of these infections can be transmitted perinatally, and HIV can be transmitted through transfusion/needle stick. Trichomonas is considered highly suspicious, and herpes and condyloma are suspicious, but note again there are exceptions to this. For example, consider heteroinoculation in a young child with a genital wart. And lastly, BV is an inconclusive infection. If you're likely to be tested on anything, it's probably going to be those top 4 infections. There are several tricks that the boards may present you with, and I encourage you all to familiarize yourself with the presentation and treatment of each of the diagnoses that I've listed. Take a look at what each presentation looks like in a visual diagnosis handbook if you have one. So Volvo Vaginitis, you may be given a history of poor hygiene or the use of bubble baths or other irritants. A foreign body can cause acute or chronic vulvovaginitis and can present with vaginal discharge, spotting, and foul-smelling odor. Vulvar lichen sclerosis. Patients can present with pruritus and genital pain, and it commonly occurs in prepubertal females. Patients classically present with this white hourglass lesion surrounding the vulvar and perianal areas, and there can also be punctate hemorrhages. Failure of midline fusion is a midline defect that can extend from the posterior fourchette to the anus. Linea vestibularis is a linear pale area that can sometimes be confused with scarring. It also crosses the posterior fourchette. Urethral prolapse can be seen in prepubertal girls and can present with bleeding, dysuria, or difficulty with urination. And knowing the anatomy will help with a question like this. Girls with straddle injuries usually have an injury to the anterior part of their vulva and much less likely to have injury to the hymen. You will likely be given a history of the straddle trauma, and labial adhesions can cause vaginal pain or discharge, difficulty with urination, recurrent UTIs, or vaginal infections. Again, being familiar with the anatomy will help. So I've listed here some of the resources I used for this presentation. I would suggest looking through anything published by the AAP or in pediatrics is going to be very helpful, particularly the Flaherty, Christian, and Kellogg articles. Thank you.